to, yeah, I'll do my best, try my best to impart whatever knowledge I have and make all the difference to our budding people who have taken out all their time and all of you people who have made it to today's session. So I'll delve into the topic fast. It's a very, very important topic, sets in the foundations for all future talks to come into play. It sets all your foundations, groundwork. It lays down all the groundwork. So pay attention, and this is going to be an important.
Dr. Swati,
Yeah,
I will take one extra moment
sure, sir.
for a few things to be clarified to our fellows. First thing that this is an effort from the IAPM to make you apprised with the current topics of the pain medicine, which are relevant to the time and which are futuristic as well. Some of these lectures will also be uploaded on our website, that is www.issp-pain.org. Not all, but only the lectures which our IAPM people will feel that they are worthy of the putting on the our YouTube channel for them to be accessed later on. Apart from that, you all are requested also to update your data as the practicing pain physician in the ISSP website again after logging as a ISSP member. With this, I would also like to request our President Sir to say a few words about our team of IAPM, who is uh, Dr. Swati is the presenter and a wonderful speaker. But I request you, sir, to mention the our gratitudes from the ISSP headquarters to our moderators and the runner of this show. So this is my and also I would like to say happy Holi because this has just passed अभी भी चल रहा है तो होली की भी बहुत बहुत शुभकामनाएं आप सभी को. So this was from my side only. Sir, one line from you, then Dr. Swati may
Yeah, yeah.
proceed with the moderator's help.
Yeah, I think that was a very important part because without the positive inputs by the moderator and especially Dr. Kashinath and Dr. Manjari Ranade, this session would not have been possible. And to be very honest, I had some goosebumps also because I had never attended previously an IPM session. So I had talked to both of them what is expected out of me, but they were so kind enough. And their basic aim was that this session should be really useful to the fellows who are going to join the session. So I think, can we now start the talk? Dr. Swati,
Yeah, sure.
the stage is yours.
Just give me a moment to share. Yeah. So my yeah. So Anshul, I've given the approval for recording. Okay. Yeah. Okay. Uh, so we're going to discuss about the pain pathophysiology and the pain pathways. And then towards the end, we will discuss a little bit about neuromodulation and neuroplasticity as it develops as a result of any disease process. So let's go straight heading into the definition and where we started all from. So, pain has been, a subject, a very elusive subject for a long period of time, into different specialities. To say the mother branch of all science or all medicine has been the internal medicine, and that is where it all starts. So, pain has had its definition and its essence right there itself. So, once the the International Association for Study of Pain came into existence, and it was 4 decades earlier that we came up with a definition of pain. However, the initial definition that we had stated pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such a damage. So this was the definition which we almost followed for many years, or I should say 3 decades we followed, 4 decades we followed the same definition. The only it came revised during the a little just away from COVID, or just when COVID hit, that around the same time or around the corner, IASP came up with a newer definition, a revised definition of pain, which stated this to be an unpleasant sensory and emotional experience associated with or resembling that association with actual or potential tissue damage. So if you see, not much was different in the revised edition or definition from the previous one, except that it took away the last part of the sentence, or described in terms of such damage. So why was this term taken away, or why this half of the segment was taken away? Because it had important ethical issues surrounding it, which meant that the earlier definition specified that it would be considered substantial, or it could be valid only if it required that there would be description to the terms of such damage, right? So the descriptiveness made it very essential, which meant if there was not a description associated with it, if anybody would not be able to describe, does that mean the pain is any less, or does that mean we negate the possibility of such an phenomenon being existent? No. So, a lot of populations, cognitively impaired, children, pediatric population, animals, would be left behind of this. When we are talking about pain, it's not only a physical sign or something, it becomes a fundamental issue. It becomes very important for anybody to be able to be taken seriously about their ailment, right? So that was a very, very important thing. That was something which was restrictive in the nature of the way it was described. So that's the part that was being taken away. So that was just to bring a little bit more clarity into why it needed to be changed. So what was the revised, or what was the overall takeaway from the definition? Pain is always a personal experience that is influenced to various degrees by biological, psychological, and social factors, or what we call it as psychosocial factors. So why we call it as that, it is influenced to various degrees, right? It's influenced by what an individual is grown up to be, right? So there are, with various ethnicities, various countries, across various regions, where individuals are brought up in a certain environment. So the way they are brought up, like for example, if you see the people in the eastern part of the world compared with the western part of the world, if we compare the threshold and the tolerance levels of pains, or the way anybody behaves in one part of the world compared to the other regions of the world, there's a lot of difference in that. So why that happens is because of this psychosocial and biological factors which have been grained or ingrained in them over a period of time, the as an individual, as we grow up seeing, or as we start responding towards that, right? So that's what it means. It's a personal experience. My pain is not what your pain could be, or one patient's pain may not be exactly the same as the other one. So we can never pinpoint and say, hey, yes. Most of the time we read in the books, in anesthesia, I remember when I did my first year. So there was one chapter which had a tabulated column, the score of pain highest being there for orthopedic surgeries, fracture, trauma, followed by labor analgesia, then followed by few others, appendicectomy, all of those, they are very less, a very rough. But can we say that that is the same exactly going to be replicated across different people? No. somebody may have a thresholds which could be very different from somebody else. So a surgery may not be really giving a lot of pain to one individual, but somebody who has a threshold, a lower threshold, or has some plasticity may respond much differently. So that is why we say it's a personal experience, right? Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in the sensory neurons. So sensory neurons are just a signaling mechanism. Pain is an overall experience. So pain is you can say it's a bigger picture in which sensory neurons are just a modality which helps in that overall perception, forming of that perception. Through their life experience, individuals learn the concept of pain, as we already discussed in the first sentence itself. So it's your upbringing, how you learn about it, right? So a person's report of an experience as pain should be respected. So if an individual says that he has pain, or he's got exceptionally high pain, or less pain, or a score of 5 or 6, whatever the individual may say, we need to, as clinicians, especially as pain physicians, we need to accept what the patient is saying. So pain is what the patient says it is. Okay. Most of the time, when we are not able to pinpoint, or when we are not able to see an obvious reason or an obvious cause for pain, we tend to call it psychological, psychosocial, right? Many times we say it's in the mind. I've seen so many clinicians say that. I don't want to name this various specialities, but when people are not able to find a reason for, they're not coming to a diagnosis, correct diagnosis, they cannot treat pain. Most of the time, they label this patient as psychotic, but it's not what it is, unless and until proven scientifically. But there are techniques, there are methods. Unless you prove that there is malingering, unless you prove that there is pain somatization, unless you prove all of these, right? Then it's a different scenario altogether. But unless proven otherwise, just because you're not able to find a reason, don't say that, it doesn't exist, right? So pain is what the patient says it is. Always believe the patient. Although pain usually, and in due course of your time in your practice, you will realize over the years, when you start believing in, when the patient starts understanding and getting a feel that the clinician is responding or is believing in what you are telling, half of his problem is mitigated. Most of the time it happens that way, right? Half of the mental agony associated with that pain is emotional. That emotional component of it, some part of, whether it is 30, 40, or 50%, whatever the component be, that aggrieving gets solemnized there itself. Okay. So never give an individual a feeling that what he's saying is not, you're not at par with what they are saying. Okay. Although pain usually serves an adaptive role, it may adversely affect on the function and psychological as well as the social well-being. So usually pain has its adaptive nature in the sense it has some features to it, which means God gave you pain as the first mechanism to signal that there was a harm, whether it's an infection, trauma, burn, or anything, so that your body takes active steps to move away from it, right? That is the component associated with it where acute pain is helpful. But over a period of time, when this does not happen, when it becomes chronic, then that is where it brings its adverse effects into functionality of the individual, which affects the social as well as the psychological well-being of an individual as well, right? It affects every quadrant of a human being's life, anybody's life. Verbal description is only one of the several behaviors to express the ability to express pain. Inability to communicate does not negate the possibility that a human or a non-human, which is animal, experiences pain. That is what I said. The last part of it was taken away because of that, right? So people who cannot express, the cognitively impaired, or the children, or anybody who's not able to speak and express or communicate, not the literate, in those cases also they should be considered very much candidates who may have the same. So this is just again bringing in the same essence. As I said, it pain when it becomes on chronic stage, it affects.
यार
It brings with it.
દિશા નહીં આ
Please mute your.
દિશા નું અહીંયા આવ્યું કઈ રીતના સબમિટ કરવાનું બકા
Please mute your speakers.
સબમિટ કર વેટ અરે અહીંયા સબમિટ કર પેલા વોટ સબમિટ કર કઈ રીતના સબમિટ કરવાનું છે આઈ ડોન્ટ નો બસ આ જો મેં કર્યું છે ને આવ્યું છે મમ ક્યું અહીંયા છે
Excuse me.
ખોલીને
Yeah. So I'm audible, right?
Yes, Swati, you are audible.
Okay, so it brings with it the emotional effects, the cognitive effects, it brings behavioral effects, physical changes, and all of these when they are not, when they are not limited to a particular time limit, this is a vicious cycle, and pain brings in increased pain and more dysfunction. So just a little bit of description as to when we divide or categorize pain into chronic as well as versus the acute pain. Acute pain is physiological in nature, has a protective role. It is very short lasting, and mostly it's a symptom of a disease and states nociceptive nature most of the times. Whereas chronic pain is something which is not normal. It's not a normal physiological process. It's a pathological condition. It doesn't subserve any protective function, right? It lasts more than the normal time limit that should be required for any disease process to become normal or the body to restore itself. Most of the time, it is of neuropathic nature, and it's not self-limiting. Okay. So it's actually a disease in itself, and that is when we call it as the disease of the nervous system, when this involves a neuropathic pain, right? Most of the time acute pain settles around when the disease is limiting, or whether it's a surgical insult, or it's a damage, or it's a tissue damage, or it's any wound or anything. Once it gets cured, there's a simple relationship between the cause and effect. Once the tissue damage is healed, pain stops and it starts healing on its own. Whereas in a pathological state of a chronic pain, even though you will not be able to find any tissue damage or anything underlying, it still may persist, and that is why we call it's called a dissociative relationship. You cannot find a cause to the proportion of pain that a patient may be experiencing, right? So that is why we call it's disproportionate to the clinical findings. That brings in this. So pain, we can also, in terms of its longevity. Usually chronic pain, like many books write acute pain and chronic versus chronic pain. Some books write chronic pain to be when pain lasts 6 months. Some books write it's 1 month. Some write it's 3 months and all. I would call that usually any state which would normally require a normal healing process, say like a surgical incision, which would take around 4 to 8 weeks for normal healing. If it does not occur during that time and pain still persists, then that is what we would call it as chronicity. So most of the times around, a rough definition would be somewhere around 2 to 3 months is something that we look at development of a chronicity. If it doesn't stop, that is when we call it as chronic. Pain can also be descriptive into nociceptive and non-nociceptive. So nociceptive is further divided into somatic and visceral type of a pain, whereas non-nociceptive is mostly divided into a neuropathic and could be sympathetic origin as well. So these are few definitions like pain threshold, pain tolerance level, paresthesias. These are all the definitions which I will not go into much into details. You can just go through these definitions because we have very limited time. I'm running already half the time. So there are a lot of other topics which I need to. So you can just go through these definitions. If at all there are any queries, please put them in the chat box. I'll be happy to answer any of them, right? So this dysesthesia is an unpleasant, abnormal sensation. It could be whether it could be spontaneous or it can be evoked. There are different types of dysesthesias, which include the hyperalgesia and allodynia, which we will delve into. Hyperalgesia, on an average, we call a state. It is an increased pain from a stimulus which normally provokes pain. Okay, something which is always supposed to be painful, like for example, if I prick somebody, it will obviously initiate a pain, right? The only difference in hyperalgesia is that normally anybody who would feel a little bit of pain from that stimulus, it may be much more heightened for another individual. That is when we call it as a hyperalgesic state. But here the increased pain is again only a, a function of the same kind of receptor what it was supposed to signal. Okay, the mechanism here remains the same. What was supposed to signal pain is still signaling the same thing. There is no difference. Okay, but just that the response is much more heightened. That is when we call it as hyperalgesia. Allodynia is a pain to a stimulus that does not normally provoke pain. For example, touch of a cold air, warm water bath, right? Touching your face. These are all sensations which normally should not provoke any pain. But if at all these sensations, once instigated, if they are provoking pain, if now a patient feels pain because of all this, that is when we call it as allodynia, right? So the stimulus leads to an unexpected painful response. Here, allodynia involves a change in the quality of a sensation, whether it could be tactile, thermal, or anything else, right? So there is a change in the response pattern altogether. Something which was supposed to signal for maybe temperature, now it's signaling pain. Something which was responsible for telling you a pressure sensation or a touch sensation, again starts signaling pain. So there has been a change now in the functionality of the receptor. That is when we call it as allodynia. I'll come back to this figure a little later, right? So the implications are in allodynia, you have lowered threshold, but the stimulus and response here majorly differ. What is supposed to be the response from the stimulus is not what you get. You get a different response altogether. In hyperalgesia, the stimulus and response mode are in the same manner. Okay, it's just that it's a heightened response of the same stimulus, right? Again, hyperpathia, it's much raised response. Hypoalgesia is when you have much lower sensation or hardly any response. But again, the response and the stimulus are in the same mode. So this is the state when we call it as sensory dysfunction or something like that. Yeah, so neuralgia, neuritis, and neuropathic pain are terms which you will come across very commonly. So you need to differentiate one from the other. Neuralgia is just a pain in the distribution of nerve, or a single nerve, or multiple nerves. Neuritis is the inflammation surrounding that nerve or multiple nerves, right? When it is pain which is caused by a lesion of the somatosensory nervous system, or when we call it as the disease of the somatosensory system, that is when we call it as the pain arising out of such a phenomenon as neuropathic pain, right? What is neuropathy? Neuropathy is when a function is already distorted, which was to be subserved by a nerve. That is when we call it as neuropathy. Okay, so neuralgia, an individual who has a prolapsed intervertebral disc, right, may just present with a radicular pain, some pain which is going down your leg or going in the arm, something like that, shock-like sensations, right? That is just a neuralgia. right? Neuropathy is when already other associated features are involved, right? When there is a damage that it has occurred in terms of either a sensory modality, you can figure out that there is some sensory loss somewhere all along the course of the nerve, or there is a motor dysfunction that is associated. That is when we call it as neuropathy. Okay, so you need to distinguish, you need to be very clear when you are documenting things. There's some another definition, very interesting, what we call it as deafferentation pain. So deafferentation pain, most of the time you will see in your clinical practice, there's something called phantom sensations or phantom pains. What are phantom pains? You would have come across amputated patients, right? They have mostly some pain when the organ itself is not there, it's removed, right? So dental extraction, so which gives a phantom tooth. So there's no tooth present, still the patient keeps on feeling. There's no leg, the patient keeps on feeling, right? It's called mirroring, right? So why exactly this happens is, as this pain starts as a loss of sensory input into your sensory or central nervous system, as it occurs, there is avulsion of, like for example, the brachial plexus or other types of lesions, right? It could occur due to pathology, basically, that occurs in your nervous system, right? So there are constant sharp exacerbations associated, and this keeps on a situation like allodynia continuing all throughout. So despite the fact that there is nothing which is inciting, there is no stimulus which is going on, but patient is going on having concurrent pain sensations all throughout, right? So what lies basically under the mechanism is that the central nervous system of these individuals, it undergoes reorganization, right? There is some interaction with the substrates of pain perception, which is called as the pain matrix. So there is some communication that occurs, or some miscommunication that occurs between the anterior cingulate cortex and parietal operculum and thalamus. All these connections, interjunctions, which take place over a period of time, that is what becomes responsible for this deafferentation pain. Okay, so that is what is called deafferentation pain. Now, in individuals, as a healthy individual, there is always two types of systems which are acting at any point of time. It's a balance, it's a wonderful balance which nature has created or God has created, right? So this balance is something between what we call it as intrinsic modulatory mechanism, and on the other hand, which is called the sensitization mechanism in the body, right? Sensitization mechanism in the body, the function the function that it subserves all the time is to intensify pain symptoms, and eventually, as a result of this intensification, patient feels hyperalgesia. At the same time, on the counterclock side, you have in the same body another mechanism which is called as a modulatory mechanism, the function of which is always to attenuate. So this works counter-regulatory or counterproductive to the previous mechanism, which is sensitization mechanism. So it works as a very good balance between the two. Okay, the function of this is to lessen this pain perception, right? So when this beautiful mechanism exists in the body, when initially you have a pain, or when you have a trauma or a surgical insult or an infection or anything, the immediate response of the body is to create or intensify this pain symptom, and patient feels hyperalgesia, right? For example, suddenly you come across a hot object, a hot iron, suddenly you touch it and you feel hyperalgesia, right? So initially you start your system is activated, so sensitization has happened in the body. But do you feel the same as time progresses? You don't, right? Over a period of time, in the first 1 hour, or maybe in the second hour, third hour, after uh, after a little bit of time has passed, do you feel the same intensity? No. How does that happen? Because your counter regulatory mechanism of intrinsic modulatory mechanism is active. So it is attenuating the intensity of pain, it is bringing it down, right? So imagine if this was not there, right? Patients would have, or any individual would have continued to suffer in that pain all throughout, right? But nature is so beautiful. It has subserved the function that it had to subserve, and it has brought back the system in place, which is the dampening effect, which puts a brake on that and attenuates this, and you feel lessened perception over. A small child falls down. Initially, child starts crying. After a certain period of time, he forgets and then starts walking again, because this intrinsic modulatory mechanism is in place. Okay. So pain is perceived as a result of um, certain nerve fibers that we have in our body. So mainly we divide it into two different types, which is the delta nerve, the A delta nerve fibers, which is responsible for carrying the sensation, the quick, intense pain sensation, and carries it at a very, very faster pace. Whereas, and these are mostly myelinated fibers. They carry they jump this nodes of Ranvier, and which is why they are very fast to carry the signals. Whereas C fibers, these are mostly the non-myelinated fibers, and that is when we call why we call them as slow fibers, and that is what carries the chronic pain or the slow pain or the after pain. So this is basically the mechanism how you perceive pain by function of these two. Okay. So these are different speeds at which they conduct, which is why they, yeah. So now there are few definitions which you need to know about the mechanism of pain. Why we are talking about all of these is when you try to understand where pain or why pain or the mechanisms, that is when what helps you to tomorrow correct the pain. Okay. So we need to know very well what is basically which underlies or at which level something can go wrong. So transduction is basically a phenomena where intense heat, cold mechanism, mechanical forces, etc., or chemical irritants, they all act as noxious stimuli. They basically activate the free nerve endings, which are called as nociceptors. They generate an action potential in the primary nerve fibers, which is your A delta and C fibers. So an action potential at a periphery end organ is generated. Okay, that is what we call as transduction. This is basic physiology, if you remember in our first year of MBBS. Once having generated that action potential, now that action potential has to reach to the brain. How does it reach to the brain? Transmission occurs. That is what we call as transmission. Peripheral A delta and C fibers carry this noxious sensory stimuli from periphery to the dorsal horn of the spinal cord. These fibers synapse again here in the spinal cord at the second order afferent neurons at the dorsal horn, and then the signal ascends upwards in the anterolateral system of the spinal cord all the way up to the brain. That is what we call as transmission, going all the way up to the brain. Once this is traveled, okay, the long pathway is traversed. Now the brain has to, some signals reach the brain. Now it has to interpret what it is, whether it's a happy sensation, whether it's a sad sensation, or whether it's a good sensation or a bad sensation. That overall perception, overall feeling, overall experience is what is called as the pain perception, right? So the interpretation and response to pain signals occurs throughout the higher centers in the brain, including your medulla. All these integrate together their actions and bring about the sensation or the feeling or the perception of pain. Okay, so there are lots of structures which are involved in the overall experience or what we experience as pain, right? So that's about it. So it's your limbic system, amygdala, all interplay between all of this, right? Eventually, once having felt all of this, there is something which is called as modulation, right? So the descending inhibitory pathway, at the same time, what was the pathways which went upwards to signal all of these sensations all the way up to your brain, right from where in the periphery they came from, it has to again now go the same pathway down, right? So this is through the descending pathway. As much as you have an ascending pathway, you have a descending pathway also through the spinal cord, right? So this descending inhibitory pathways combine with other external inputs to contribute to modulation. It puts a damper, it puts a rider, it puts a brake on this pain transmission in the dorsal horn within the spinal cord, and that is what we call it as modulation. So it's the sum total of these mechanics in the body that constitute your pain pathway. Right. So eventually, pain is an overall experience which is brought about by lot of different components, which is subjective in nature, contributed by the cortical part of the brain, the affective or the thought process that is brought about or taken care of by the limbic system of the brain, the prefrontal cortex, which brings about the pain anticipation. You start thinking or start associating memories with pain, what happened the last time, that is all called anticipation. And there are again other parts of the body like the medulla, the hypothalamus, etc., which coordinate the visceral and neuroendocrine system, which is responsible for bringing this overall effect, right? It's a cause to effect, and likewise as well, right? So pain is got multiple factors to it. It's multifactorial, and it's multiple uh, in its system or in its behavior as well, the way it is perceived. So basically, this is one of the beautiful pictures to show how your different receptors exist in the body. There are different kinds of receptors. You have free nerve endings, you have encapsulated ones, you have sensory cells, peripheral processes with one cell having multiple processes, few of them having only one single cell. So all of these remain the in different fashions. They subserve their cell bodies somewhere in the sensory ganglia, and then they have their main loci or or they are grounded or rooted into the central nervous system, is how their origin, or this is how their entire circuitry is situated in your body. So this is just a rough diagram as to show you how all of this pans out. So nociceptors basically are primary afferent neurons for pain with specialized nerve endings. They respond to different types of noxious stimuli. They could be any kind of a stimuli, whether it's chemical, mechanical, thermal, and they are characterized by different types of stimuli, different types of classes that they subserve. Their responses could be slow, fast. The latency can be different. Some of them can have fast latency, some of them can have short latency, some of them can have long latency. They're also very selective in the channels that are expressed on the membrane. So while all of them are so highly characterized, why all of this occurs is because nature has provided every neuron in such a way that it is very specific, right? A specific neuron will only fire or get stimulated only by that function that it has to subserve. Fast, so fast. Slow, slow. If it is pressure, it is pressure. If it is temperature, it is temperature. Less temperature, less temperature. It cannot be any variation between, right? Because it has to signal a human. This is the only source which exists between the individual and the external world. So it is very specific, right? Cellular functions of nociceptors. What are their functions? Transduction. They synthesize and release a lot of these neurotransmitters, neuropeptides, neurotrophins, glutamate, inflammatory mediators. All of this are the functions that nociceptors will function as. Okay. So yeah. So when you have these nociceptors, when you have different types of neurons which are responsible for different types of uh, signals, they are from research we have found out that they are placed in the body or in the spinal cord in a certain topographical manner, right? And we have divided, or when we have taken sections of this, we have found out that in the spinal cord, right, where you have most of your cell bodies of these neurons, right? So something called as a bulb of cells collected together. That is what we call as the dorsal root ganglia, which harbors all the cell bodies there. Okay, and mostly these are your proprioception, touch, and also the ones which are contributing to the pain and heat. So the cell bodies of all of these neurons are glazed in the dorsal root ganglia. So your dorsal root ganglia becomes a very, very important place or signaling thing that we have in our spinal cord, or we have in the entire uh, structure of our, so to call it as the central nervous system when we look at pain pathway, right? From there, we have these neurons or these fibers. They come and lie themselves in a different manner, specifically in a particular manner, right? So we have divided the entire cord into sections from posterior to anterior, and we have divided them into, named them into zones, and we call them as the rexed laminae, right? Where you have you call them from right from posterior to anterior. Posteriorly, you call them as 1, 2, 3, 4, right up to the center, and then you divide them further in the front. So this is just to show how these are placed in a specific manner. So pain system controls its sensitivity through a primary synapse. Now, what is this primary synapse? Where does this primary synapse take place? It's at, again, the spinal cord at the dorsal horn. Okay. So primary afferent neurons of pain system, they activate these nociceptors, right? The nociceptors get activated, or they secrete once the signal is received. There's the release of glutamate and substance P. Once there is substance P and glutamate, these are pro, okay? They are pro pain, I should say, right? So they stimulate this pain perception. And that is why the action potential at the dorsal horn is potentiated or started. That is how it starts. On the other side, the pain, again, same afferent neurons over here also have another role, that they will stimulate the inhibitory interneurons. The function of this inhibitory interneuron is to secrete GABA, glycine, noradrenaline, and serotonin. Right? So when this happens, this acts as a negative feedback. The action of all of this is going to dampen this action potential at the dorsal horn. So this remains as a cycle in its own way, and there is a classical balance between the two, such that the inhibitory neurons always will keep this check on this action potential at the dorsal horn. If there is any, now imagine if there is any situation where this inhibitory interneuron loses this function, what is going to happen? There is going to be a perfect chaos, right? There is not going to be any break on this dorsal horn action potential. That is what is responsible for continuous pain, or that is what is responsible for neuropathic pain states to occur. Okay. So we have mostly our neurons, which we spoke about the first order neurons. We have the second order neurons, which exist within the spinal cord, right? And we categorize them between the high threshold and the low threshold, or wide range of thresholds. The high threshold ones are very specific, nociceptor specific, whereas wide dynamic range ones have a, as the word suggests, they have wide dynamic range. So they have inputs both to noxious as well as innoxious. They respond widely to a lot of stimuli, right? They're not as specific as to the high threshold ones. So mostly the high threshold ones receive their inputs from A delta C fibers and are abundantly placed in your lamina 1, while as the wide ones are mostly the A delta, beta, C, and they're mostly in the lamina 5. The major difference being the wide range thresholds have large receptive fields, whereas the high threshold ones or the nociceptor specific ones, they have small receptive fields, right? With the result, you can be very pinpoint to when high threshold receptor is stimulated, you can pinpoint and tell exactly where it is coming from, right? Whereas when vague pains, visceral pains, right, they are stimulated by wide receptors, okay, which is why may not be able to tell clearly where they are coming from. So again, just a recapitulation, elements that contribute to the nociception are your primary afferent neurons and synapses, interneurons, which form your interconnections, which lie majorly in the dorsal horn as inhibitory as well as excitatory. And then the second orders, which play a messaging role at the and project it to the brain. So all the way into the spinal cord. And then you have the descending axons, which modulate this nociception. Most of the time, your what lies at the microscopic level is your AMPA or kainate receptors and your NMDA receptors. I've got papers on this as well, so I'm not going into more details on this because we don't have time on this. If anybody is interested in this, I can send you those papers as well. So, yeah, so this is exactly how the pain pathway exists, right? So when we have, let's understand this. When we have a stimulus which is coming from, say, like hand, right? Uh, an individual perceives the pain or a trauma. There's transduction, signal transduction, there's propagation of wave, it starts and the sodium channels start firing. It goes all the way, reaches to the first order neuron, goes all the way, reaches up to the dorsal horn, crosses to the other side, and moves all the way to the, it goes all the way and goes through the spinothalamic tract, reaches all the way up to the brain, right? So this is how the pain gets carried. There is also another pathway that is occurring at the same time, which is the, yeah, so which is the spinothalamic and the spinoreticular pathway, which brings about an emotional component to the pain. Okay, so one is the sensation, sensory experience that the individual feels. Alongside that, also there is some expression that occurs, which is not so which is not so enriching. Most of the time, pain brings with it an emotional experience, a saddening experience, right? So people are sad, crying. They are all emotions which come with it. So that is again a constituent which is subserved because of this tract, right? So that is responsible for the emotional component which is associated with pain. Once this is what we call as the ascending pathway, right? So it goes all the way from the medulla to the pons, midbrain, and all the way ascending upwards. It reaches to the third order neurons in the brain, and there is again a matrix over here. So the cerebral cortex, along with other areas, the limbic system, etc., perceives, and that is how pain is perceived, right? At the neuronal or at the microscopic level, what is happening is nociception as a result of the receptor response that occurs, and that is how transmission takes place. So, microscopically, or again at molecular level, what is happening? Nociceptor activation takes place in response to painful stimuli. A wave of depolarization is set to the first order neuron as a result of tremendous amount of sodium influx and potassium rush out, which causes at the dorsal horn, it causes or opens up the presynaptic voltage gated calcium channels. There's tremendous amount of calcium influx, which causes release of glutamate and substance P at the dorsal horn. Again, this glutamate and substance P release binds to NMDA receptors in the second order neuron, bringing further depolarization. This depolarization keeps ascending all the way up to the thalamus, and that is how synapse eventually occurs at the third order neuron at the between the limbic system and the cerebral cortex. So this is what is happening at the molecular level, how the different ionic channels respond in different ways, one after the other, and gives rise to the perception of or carry forward of pain. Right? Descending pathway on the reverse side starts from the periaqueductal gray, okay, and then there is all the way a system in the midbrain which constitutes your midbrain pons and medulla. Central to this is your nuclei, raphe magnus, okay, which comprises of a lot of nuclei, which is your periaqueductal gale, nucleus cellulus, locus cellulus, you have reticularis, dorsopontine, tegmentum, etc., rostral ventomedulla, and nucleus raphe magnus. All of this are what is the mechanism underlying your descending pathway. Entire circuitry occurs, or the modulation occurs over here only. Okay. So what happens as a result here now? The first order neurons become what is there. Now start from the brain level, right? Your anti-nociceptive neurons, they originate in the brainstem. So this becomes your first order neuron, travels downwards through the spinal cord, synapse here again with the second order neuron at dorsal horn. Neurotransmitters release serotonin and noradrenaline. So serotonin and noradrenaline are the breakers, right? Once they are released, they release enormous amounts of endogenous morphine, which causes inhibition of the substance P and nitric oxide release, which causes again a dampening effect and stops the nociception from working any further. This is totally counter to how the nociceptive mechanism started, what we saw in the previous slide, right? So basically, it is what lies here is the closure of this opiate receptor, which does not allow any further nociceptive impulse to get released into circulation. With the result, there is no antigen antibody mechanism that takes place here. As a result of this, there is stoppage of the any perception being carried forward. So that is when we call it as nociceptive inhibition. So what is exactly happening again? How does the opioid receptor function? What it is doing is when the opioid receptors are released, right? At the sensory neurons, when these opioid receptors are stimulated, they normally open the chloride ion channels and they block the calcium channels to inhibit firing of the sensory neuron. Okay. On the other side, the opioid receptor, again, these opioid peptides, so on the other side, the opioid peptides and opioid drugs, they open your ligand-gated potassium channels to decrease and the intensity of depolarization. So what is happening on either sides? If you see, there is a positive ion which is being created, or positivity which is created extracellularly, right? So potassium outside is tremendously increased on one side. On the other side, the calcium increase causes again a hyperpolarization. So with the result, both the sides, there is hyperpolarized state which is produced. As a result of this, further depolarization does not occur. And that is why that brings in nociception into existence, right? So substance P, along with glutamate and other pain-producing neurotransmitters, they produce depolarization potential in pain neurons, which is inhibited when opioid is released or opioid receptors are activated as a result of either opioid drugs, morphine, or opioid-like drugs, by just creating a hyperpolarized state across the membrane on either side, presynaptic as well as postsynaptically. So presynaptically, it is the calcium efflux, and postsynaptically, it is the potassium hyperpolarization that is created. There's some important phenomena which is called as the gate control theory. Now, gate control theory explains, this is many century back that this came into existence. This was given or coined uh, to understand the pain signals can be interrupted in the substantia gelatinosa of the spinal cord. And this acts as the gate in its own self. This substantia gelatinosa part acts as the gate, wherein if a certain kind of signals can be interrupted, or wherein certain pain signals, if they are stimulated, they can interrupt certain other signals. So what was that signal? A painful stimulus could be dampened by substantiating or by uh, modulating, right? It could be modulated by activating the deep touch, right? So how does that happen? The deep touch sensations, which are carried or which are transmitted by the Pacinian corpuscles at the microscopic level, this is carried, or the sensations are carried through the dorsal column meniscus, right? So medial lemniscus carries these sensations, right? Now, the painful stimulus, which is subserved by the A delta and C fibers, are your primary neurons, which also are carried through the same, but they are very weak fibers or thin fibers. Once these deep sensations or deep touch fibers get stimulated, they bring about or they cause the closure of this cells at the substantia gelatinosa. Okay, so there can be only, you can imagine it as a stronger sensation which is carried by the thicker fibers or deep touch sensations, right? If they get stimulated, the eventual knock is there's a knockdown of the weaker sensations, which is carried by the A delta and C fibers. With the result, they are dampened, or they are not allowed to cross this gate at all. Right? This is what was called as the gate control. And as a result of this gate closure that occurs at the substantia gelatinosa, allowing only one type of sensations being carried or traveled all the way up to the brain, we can use this and stop those pain carrying or weaker sensations which are transmitted by the A delta and C fibers. This is what is called as the gate control theory, right? And this is how normally we how do we understand this gate control theory in our reality or in our life? Whenever you have a cut or you fall down, the normal tendency is to hold that part of the body, or you rub that hand, or you pressurize that part, right? You pinch the part which is cut. And then after some time, you do not feel, right? When a child falls down, you rub that part and then he forgets, right? So how does that happen? Or in layman's day-to-day activity, whenever you have back pain, we try to massage it with some oil or the other. So what are we doing? We are activating those Pacinian corpuscles, that deep touch sensation. With the result, what are we doing? We are only giving our brain one kind of stimulus or feed, right? Which in itself stops those fibers or those sensations which are carried by the pain, or what we were perceiving as back pain, by subserved by A delta and C fibers. So eventually we are again doing the same thing, right? So this is at the day-to-day life level, right? There are certain gadgets which we use, which are continuously either by way of mechanical stimulation, or you have those chairs which you have in the malls and all, which give that sudden sensations of churning and all those things. Again, they are all based on the same gate control theory. And we have come to this day where we have implantable devices in the form of spinal cord stimulator, where we are doing nothing else, but again, we are stimulating this dorsal column of the medial meniscus system, where they get activated, and thereby they bring, we use them in very, very chronic states of pain, which are totally resistant or calcitrant to any treatment altogether. So there we use spinal cord stimulation that underlies this technique. My slide is not moving. Yeah. So again, these are a lot of, so this is to understand like how our different ascending and descending pathways are there, and how we can use different techniques and at what level they work. We have pharmacological, we have non-pharmacological. They work at different levels. What we understood as pain: transduction, transmission, perception, modulation. So depending on where we feel the problem could be there, we could give solution at any of these level, or what we call as multimodal analgesia, is where we can use, or where we can use different technologies or different pharmacological as well as non-pharmacological or interventional techniques to combat all of these, or few of these, or multiple of these processes, in order to give the best relief to the individual, right? So to bring that into essence, when we are talking about different techniques, what I said, as we can, when we talked about transduction, right? We talked about transmission, we talked about modulation. So we use different techniques in pain management, like for example, when we are using peripheral nerve stimulators, or when we are using the blocks that we use during anesthesia or analgesia, long-term analgesia. What we are doing over there is we are blocking that transduction, right? When we are using NSAIDs, right, we are blocking that initial formation of that noxious soup, right? We are reducing that substance P accumulation in the surroundings. So transduction does not occur only. We are stopping it at the very inception point itself. So our NSAIDs, antihistaminics, opioids, all of them we can use to combat this, or we can stop the transduction at the very initial step. Okay. Moving further, we can also reduce this transmission using local anesthetics, opioids, right? We can use, when we use opioids, when we combine them with local anesthetic blocks, what we are doing when we are doing the subarachnoid blocks, or when we are doing the epidural blocks, when we are doing transforaminal epidurals, we are using that as a technique over here, right? So sympathetic neurolysis, transforaminal epidural, or pulse radiofrequency ablation, we are using all of these techniques to stop this transmission from occurrence, right? Again, going way forward, as we said, modulation is where there puts a dampening system in the descending pathway, right? So we can modulate here also, right? When we are using opioids have their way in existence throughout the spinal cord, right? You have opioid receptors all throughout the spinal cord. So they bring down this. You saw in the previous slide how opioids function to modulate the pain perception, right? Alpha agonists, NMDA receptor agonists, antagonists, all of these work their way in using or amplifying this modulation or amplifying this dampening effect of descending inhibitory pathway. Okay, so that is all that can be taken use of and made use of. Intrathecal pump, spinal cord stimulators, again, these are the different techniques that we are implementing to uh, at different stages of the pain mechanism, right? Each of them works on a different mechanism. Knowing all of them and what we can do and what we are best at doing, we can always give relief to the patient. So, coming to the last part of the thing, we have a definition for neuropathic pain. Neuropathic pain is defined from the IASP as pain which is caused by a disease of the somatosensory nervous system. It may be a disease or it may be a lesion of the somatosensory nervous system. So that is what the latest definition is. This definition comes a lot of times in a lot of Viva questions or MCQs, so you should know this. Right. So what exactly happens as what do we understand by neuropathic pain? Under the mechanism, the basic fundamental which change which occurs is sensitization that occurs is something which is disproportionate or inappropriate response to a normal stimulus. That is what we call as neuropathic pain state, and sensitization is a constant feature of this neuropathic pain, okay, which is an inappropriate or disproportionate response to a normal stimulus. Neuropathic pain results or develops as a result of lesions or disease affecting the somatosensory nervous system, either in periphery or it could be central. There's always, or it is characterized by spontaneous ongoing shooting pain and is evoked amplified pain response after a noxious or non-noxious stimuli. Usually, pain as a subjective sensory system is not visible, right? So it is difficult to measure, involves not only physical aspects, but also, as I said, psychological and emotional components. Anything which becomes chronic, as I said, pain has both the sensory as well as emotional component to it. It will bring with it those changes as well, right? Symptoms of neuropathic pain, pain in the area of sensory loss, hypoesthesia exists. There is allodynia, which means there is constant pain even without any stimulation. Also, there is hyperalgesia, which means pain on stimulation, hyper pain on stimulation. The character of neuropathic pain would be burning, shooting, sharp like, stabbing, electric shock like. So, all sprouting type, these are all the associations. Burning, these are all the abstract words which patients explicitly experience or may express. Okay, associated symptoms could be numbness, tingling, pruritus, feeling of pinpricks, needles, sometimes chilling, icing, numbness. These are also could be present. When the sympathetic nervous system gets involved, it could bring with it features of sympathetic involvement, which is redness, edema, painful joint movements, decreased skin temperature, fall of hair, brittle nails. All of those could be present. I was talking about this picture. So this is a picture to beautiful picture to understand or give you perspective of how does, as pain progresses from a hyperalgesic state to allodynia, how does the normal response of the body change, right? This is on the, you can see on the vertical axis is the pain intensity, on the horizontal axis you see the stimulus. In a normal individual, as the stimulus is initially very low, there is no response at all, right? Which means the patient does not feel, any individual does not feel any pain, right? As you increase the stimulus, as I start giving stimulus, or as I start piercing, or as I start stabbing with more and more pressure, the pain starts on this scale, the intensity starts to increase. So you see the line of the blue sigmoid shape, right? And it keeps on increasing, increasing, increasing as the pain intensity is increasing. It keeps on increasing as the stimulus is given increased, right? This is a normal response. What happens in a hyperalgesic state? Now, compared to the intensity of pain that a normal individual would feel, a patient who has hyperalgesic state will respond more painfully to a stimulus at a little earlier intensity only, right? So you start having the signal of pain intensity much earlier, right? Probably at an intensity where a normal individual didn't even feel, but somebody who has hyperalgesia may start feeling a score of 4 already. That is a hyperalgesic state. What happens if this pushes even further leftwards? There is complete shift of this curve towards left side. That is, even despite no stimulus being given, right? There is no stimulus. Then also pain is still persisting. Can you see this graph over here? There's hardly any stimulus. That is how allodynia is. Okay. In hyperalgesia, to a lesser intensity of stimulus, pain is responding, right, compared to a normal individual. But allodynia is a state where there is no stimulus at all. There is some intrinsic activity which is constantly occurring at the normal level also, at a non-evoked level also. When you're not giving any stimulus at all, then also there is repeated firing which is taking place at the dorsal horn, which is constantly going or signaling as a pain perception to the brain. That is what it is. So what underlies this change of constant firing? This is what we call as neuronal plasticity of the nervous system, right? There is plastic changes, there are neuroplastic changes, there are anatomical changes which take place into the nervous, entire circuitry system of the nervous system of these individuals, which brings about this neuroplasticity, and that is what causes this thing to occur, or which causes the propensity or the formation of this neuropathic pain state to occur. So as a result of this occurs, as a result, what happens in this picture, right? So you can see this picture, right? What is happening over here? You have, suppose there's a cut, okay? So what happens as a result of this trauma? There's a surgical insult, or there is a trauma, patient falls down or gets hit by a hammer or something. So as a result of this, what happens? Primary inflammatory mediators will be released into the immediate circulation. So there's histamine release, leukotrienes, norepinephrine, cytokine, bradykinin, purine, hydrogen plus ions. All of this is your noxious inflammatory soup that we call as. This is all that is responsible for all that throbbing sensation, all the pain that occurs anywhere. These are your inflammatory, pro-inflammatory cytokines. Okay. This is what is responsible for the primary pain. This is what we call as primary hyperalgesia. Okay. When this stays for a little bit of time longer, right, it brings with it sensitization. That is what we call as peripheral sensitization. Now, from the area where it was hurt, it starts affecting the nearby structures, the nearby nerves, the neurons surrounding. That is what brings as the peripheral sensitization. Now these neurons surrounding are sensitized, they are firing. Normally, as nature would have it, this should get subsided on its own if the intrinsic mechanism is working well. If not, and you are giving medications, you are using NSAIDs, you are using different types of mechanisms, this should settle down. If it does not settle down, this peripheral sensitization is going to cause secondary hyperalgesia. How? Because this will get propagated further and further. There is going to be some phenomena, what is going to be called as spinal windup, which means these firings will keep on going to the dorsal horn at the WDR, at the substantia gelatinosa level. It will keep on firing these low amplitude waves. Over a period of time, these low amplitude waves will summate and form a bigger wave and will keep on getting transmitted to the higher center of the brain, and that is what is called as spinal wind up phenomena, and that brings in the central sensitization. This is what underlies central sensitization. So central sensitization occurs as a result of there is certain processes which are taking place to aid this central sensitization or to aid the spinal wind up, which is neuronal sprouting, right? Lots of new neurons get formed. There's receptor upregulation. Certain receptors are there which were not taking place or taking part in previously reactions, pain reactions, but now suddenly they also start contributing to that pain pathway. So that is what we call at receptor upregulation. There is ectopic impulses. The previously non sprouting or non taking part, or those ones which were totally dormant, now they also start firing. There is neuronal crosstalks, which means now certain nerves will interdigitate and form cross connections somewhere else, which they were not supposed to do, right? And there is also disinhibition. So what is disinhibition? What was supposed to inhibit, you remember we talked about the primary afferent, right? It has two limbs, wherein one, it potentiates at the dorsal horn with the secretion of substance P, right, and glutamate. On the other hand, it was also causing inhibition, right? Now there is disinhibition. There is something which goes wrong in that circuitry, and this inhibition is not at all functioning properly, right? It's like the brakes of a car get failed. Okay, so when that brake has gone, there is disinhibition. Now that inhibitory system is gone completely. So this is what is responsible for the overall experience or overall sum total, what brings your neuronal plasticity and which causes central sensitization to occur. This spinal cord reorganization. Yeah, so this is what I was talking about. There is this inhibitory interneurons which loses its functionality, and that is how this action potential at the dorsal horn keeps on potentiating, and that is how there's a propagated state all the time. So what from research, it has been seen that these glial cells, which normally were supposed to play, or we were thinking that their vital role in modulation, amplification, and distortion of the sensory impulses is quite important. These glial cells also they activate the DNA and they start synthesizing some new proteins. Okay, as a result of this new protein synthesis, there is constant interaction with the adjacent nerves, and a lot of tremendous amount of neurotransmitters get released, and they keeps on activating further these glial cells, and this starts working as a positive feedback loop, and pain starts being potentiated as it continues as a cycle, and that is when we call pain becomes disease in its own self. Okay, so sensitization of primary afferent terminals causes hyperalgesia. This allodynia, as I said, the active nociceptors become sensitized and sleeping ones get awakened, and constantly there is firing of these neurons. So there's allodynia. These damaged sprouts, they form collaterals, cause increased area of pain. So it starts increasing from one area to the other. So larger area being involved. Ectopic discharges again starts discharging all along the nerve fibers, dorsal root ganglion, right? So patients remain awake throughout the night. It starts firing on its own, even when the patient is sleeping or may not be moving. So it's like not evoked. You don't have to do anything. Spontaneously, pain will keep on firing all the time. That is what is chronic pain, right? And then when when the sympathetic nervous system gets invaded, you have symptoms which are brought by the control systems, which is edema, color changes, etc.
Dr. Swati, how many slides are
No, that's
there?
all, sir. We are done.
You're
So
done?
yeah,
Okay, okay.
sensitization results into increased intensity of pain, area of pain, duration of pain, decreased tolerability, and psychological problems, and pain becomes non-responsive to conventional analgesics. So these are different types of neuropathies which are responsible for this. You can just go through all of them, and I'll share with you a lot of these papers which I have, from which we have drawn this presentation. I know it's been a little overwhelming for you to go through this in a short span of time, but I've tried to put this in a gist.
I really agree, Dr. Swati, that the topic is quite long and the time given allotted to you was quite short. And still, you try to cover so many things and in such a nice manner. We are really thankful to you. And I think the fellows must have really understood the topic so well. Are there any? Uh, I have a few things. Only in short, I would like to just stress upon that we were discussing about serotonin. Like there is substance P, it always has a fixed effect, but chemicals like serotonin has a changed effect. Sometimes it is pro-inflammatory, and sometimes it is inhibitory also, and that depends basically on the receptor on which the
Yeah.
serotonin is acting. So that is what Dr. Swati was trying to stress upon. Then there is she has also stressed upon allodynia. I would like to just emphasize, other than static, there is also dynamic allodynia. In middle, she was stressing upon it also. So dynamic allodynia is also very important for clinical examination because it specifies the involvement of the nervous system. Different fibers are involved, different corpuscles are involved, so that is a different picture. Then one more point which is important is the involvement of the hypothalamic pituitary axis, which also plays a very important role in central sensitization, which is also very quite important. I think the rest of the things you have covered so well. I don't need to stress upon anything in case somebody, and I don't think there are any questions.
No questions in the chat box.
No questions. That means everything was clear.
Uh,
Mm.
it's a little overwhelming topic for anybody
Yeah,
to,
yeah, yeah, yeah.
understand it in the
But I think if you keep on reading it again and again, if your
yes, yes,
recorded messages, recorded program is there with us, with
yeah.
the fellows, then gradually, with due course of time, it'll be
I'll
easy
share
for
with you.
them.
Yeah, I'll share with you a lot of few of the literatures which is available. Some few
Yeah,
papers
that's
which are like
important.
very
Yeah,
good. I'll
yeah.
share with them with you in the group. So please go through those, and don't get overwhelmed by all the definitions or whatever we have spoken. I'm very sure nobody will be able to take back home today. Whatever everything information we have given today, but
It is like
something.
Sanskrit. It is like Sanskrit. If you want to impress somebody, you start talking about neuropathic pain. But
Yeah.
keep
So,
on
but
reading it. Keep
yeah,
on reading
it's
it.
basically a phenomenon.
Yeah.
It's a lot of philosophy behind this. So once you keep reading it over and over again, later a point of time, it comes very slowly, it comes very smoothly to you. So just keep going through in due course of time. Of course, over the next 1 year, you will be listening to these topics and these terms very often. All of them will make sense to you as
I
you
hope the fellows don't suffer from the wind up phenomena, hearing it repeatedly, repeatedly.
Yeah.
Okay, Dr. Sadi, thank you once again, and thank you, Dr. Manjari, and I think Dr. Kashinath I don't think he's there, but still my thanks to them. Thanks to our secretary, Dr. Anurag, and Anshul is also there. Thank you, and thank you all the fellows for joining us for this first session. Thank you.
Thank you, sir. Thank you, sir. It was great. Thank you, Dr. Swati. It was a great lecture. I
Thank
think
you.
we should
Thank
wind up
you.
for
Thank you,
today.
Madhaji.
Yeah.
It was a great lecture.
Thank you. Thank you.
Thank you, Madhaji.
Thank you. Bye.
अंशुल आप रिकॉर्डिंग स्टॉप करोगे ना? आपका म्यूटेड है. I'm not able to hear you.
Swati, probably आप कर रहे थे recording? Yeah.
मैं स्टॉप करूं?
अच्छा.
हाँ जी.
Okay.